Okay, good afternoon and welcome everybody to the most recent or May 2015 update to the DOPS Practice Monitor findings with our data through December of 2014. And we really thank you for joining us and also for your active participation in today's WebEx. With that, Ron?
Thank you so much, Bruce, and hello, everyone. Hope you're having a great afternoon. So if we could go on to we've got a few poll questions here. So we thought we'd ask a few questions on the buttonhole technique for cannulating an AV fistula. And so here's the first one. For patients dialyzing with an AV fistula in your unit, what percent are cannulated using the buttonhole technique? And so there are about 6 different options there for responses. I guess we'll just wait a minute on this one, and then, or I can just go on to the next one. Okay, thank you, Brian. Brian, so great. Okay, and so in addition to that, we have this other question. How are the current quick measures in vascular access affecting the focus on vascular access care practices in your dialysis unit? So for an AV fistula use, is there even greater emphasis now than there was before with the new quick measures being in place, or is there little to no change in your emphasis? Now, there could have been a large emphasis in the past, and there continues to be a large emphasis, so I suppose then in that case there wouldn't be much of a change. But so the question here is, has this resulted in an even greater emphasis than there was before? Then a similar question then for AV graft use with the current quick measures on vascular access. Has this affected your emphasis on graft use? Is there maybe even a greater emphasis on using grafts now? For instance, as a means to decrease catheter use in patients for whom fistula doesn't appear to be possible. And then the last one is how the current quick measures on vascular access may be affected your care practices and minimizing access-related infections, and whether there's now a greater emphasis or answer choice B is little to no change in emphasis. So if you had a chance to provide your responses on those, that would be great, and then we'll get back to the answers later on. So then we'll go on with a few slides here. And many of these are based on a recent paper that we published in Trends in U.S. Vascular Access Use, Patient Preferences and Related Practices, which was based largely on the U.S. DOPS Practice Monitor data here, along with some international comparisons. And this just came out in AJKD a little bit earlier this year. I believe it was published in February, something like that. Okay, so the next slide. So the U.S. Fistula First Breakthrough Initiative, KDOQI guidelines, and many national guidelines have recommended an AV fistula as the access of first choice for hemodialysis, essentially across all countries. However, despite that, we still see quite a bit of variation in vascular access use and fistula use, for instance, across different countries and across facilities in each country. So then going on, we thought then we would look at recent trends in vascular access use in the United States based on the DOPS Practice Monitor, and this was based on about 3,400 patients in the U.S. from 2010 to 2014, and then in addition an international comparison in DOPS-5 from 2012 to 2014, based on 8,500 patients in 19 other countries. And so this first slide shows the trend in vascular access use in the United States from August 2010 to August 2013 from the DPM. And as a historical comparison, we're showing what it was in 1997 when we first published on vascular access use in the United States at that time. So back in the old days, 24% of patients were using a fistula, 49% were using a graft, and 27% were using a catheter. So then we fast forward 13 years to August 2010, and you can see through all of the initiatives that have gone on and efforts at the dialysis units, that fistula use has increased dramatically from 24% up to 63%, and catheter use has declined from 27 to 19%, and graft use, as you can see, has declined greatly from 49 down to 18%. So most of the fistula gain from 24 to 63% was at the expense of basically grafts being going from a graft-based practice to a fistula-based practice. However, since August 2010, there have continued to be improvements, and as you can see, the fistula use is increased from 63% up to 68% by August of 2013, and catheters are still continuing to decline, now close to 15%. If you look at the DPM, the latest DPM website, we show fistula use at 67%, and that's with the addition of 107 non-LDO facilities. So we're seeing a fistula use rate currently in the United States right around 67%. Okay, next slide. Okay, so this slide, is the international comparison showing vascular access use across 21 countries in DOPS. And as you can see, there's large variation across countries. The three countries with the highest fistula use are China, Japan, and Russia, where it ranges from 87 to 92%. And then in Europe, it's really the UK, Germany, and Turkey at 80 to 83%, Australia, New Zealand at 82%. The United States is right there in the middle at 68%, and then from there down to 49% in Canada. With regard to fistula use, it ranges from 2% in Japan, 6% in Russia, and then about 10 to 15%, about half the countries, and then 25 to 45% in the remaining countries, with Canada having the highest catheter use at 45%. The United States is the only country with graft use of 18%, and essentially all the other countries it ranges from a couple of percent up to 10%. The next slide. In the United States, then, we thought it would be interesting to see, well, how does vascular access use vary across different age groups? And here you see 4 different age groups that are approximately quartiles. And it really, when you look at it, actually going into this, we thought, well, it's probably going to be quite a bit different among elderly patients, but it's really not that much different. Even in patients who are 75 years and older, it's still 65% of patients with a fistula, compared to 66 to 68% among their younger counterparts. And then catheter use really is not that much different in the older patients as well, 18% versus 14 to 17% in younger patients. Next slide. Another interesting aspect was to look at vascular access use by racial and ethnic groups. And here we see that among Hispanic and non-Hispanic white patients, 70 to 74% of patients are using a fistula, and 14 to 17% using a catheter. And among black patients in the United States, 58% are using a fistula, 26% a graft, which is twice as high as in Hispanics and non-Hispanic whites. And catheter use is very similar at 16%. Now, there may be an anatomical reason, possibly, for the higher graft use among black patients. We don't know that for certain. In a recent study, it's been shown that vessel diameters are substantially lower for black males for the cephalic and basilic vein vessels. And so it may be one of the reasons why it may be more difficult in some black patients then to create a fistula. And we'll have to see as with further work in the future if that's really the explanation for this. Then going on from here, then we also looked at vascular access use by race and sex. And here you'll see that really the pattern is that there are 2 patterns to note here. One is that among females, that catheter use is a bit higher, both in blacks and in non-blacks. So in black females compared to black males, it's 19% versus 13% in terms of catheter use. And then in non-black females, again, 19% catheter use compared to non-black males at 14%. The other difference here as well is that if you look at graft use, again, it's higher among black patients than non-black patients. But again, with females in both groups, graft use is higher than it is in their male counterparts. So those are some of the differences in access use by race and sex. Next slide. This slide, we looked at preferences for type of access by race and sex, and I think one of the key points here is that if you look at preference for an AV access, it's lower among females than among males, and that's consistent both in black patients and in non-black patients. So among females, it's about 8 to 10 points lower for preferring a fistula or graft compared to their male counterparts. Okay, next slide. Thank you, Lindsay. And also I want to give great credit here to Lindsay Zappel, who did all the analyses for this vascular access paper, and it was really fabulous work. So here we're looking at the timing of first nephrologist care before starting dialysis and how it differs across countries. And as you can see, there's a really large variation across countries. If we focus on the gray bar, which is the upper bar, upper portion in each bar, you see that the percentage of patients who have seen a nephrologist for at least six months or longer ranges from 26% in China, 59% in the United States, and then 80 to 83% in Sweden and Spain. The United States and the UK, and if the patients who are not seen at all prior to starting dialysis by a nephrologist are highest. Actually, in the US, the UK, and Russia, where 17 to 26% of patients have not seen a nephrologist before starting dialysis. And so those reflect a lot of urgent starts in that case. And then the percentage of patients seen by a nephrologist for 4 to 6 months, as you can see, is really a relatively small fraction of typically 5 to about 10% in most countries. Next slide. In this slide, we're looking at what kind of access patients started dialysis with, and this is in the DOP study among patients who are already on dialysis for up to 60 days at the time that they enrolled in DOPS. The median time was about 35 days. So these patients, this distribution of vascular access use is not necessarily right at the first day that they started, but on average is about 35 days after starting. And despite that, you can see that there are large differences across countries. In the United States, 28% of our patients were starting dialysis entered DOPS within the first, let's say, 35 days with a fistula, and 67% with a catheter. Whereas in Japan, as you can see, 84% were starting with a fistula, and Turkey, and Italy, Germany, the UK, Spain, and Russia, over 50% of their patients initiate dialysis or close to the time of initiation with a fistula. And catheter use is generally less than 50%. If you look at other data that at patients who really, at the time of starting dialysis or at USRDS data, you'll see that about 80% of patients are starting dialysis with a catheter and about 18% with a fistula. So the next slide. In this analysis, it's similar to the prior one, except requiring that everyone had seen a nephrologist for at least 4 months before starting dialysis. So theoretically, sufficient time to have placed an AV access and potentially to have it start when needed for dialysis. And again, the great majority of these patients, though, have been seen for more than 6 months. Even though everyone here is more than 4 months, the great majority of these patients have been seen for more than 6 months. And despite that, in the United States, only about 38% are starting with a fistula and 57% with a catheter. And this is even allowing for for patients actually who've entered the study within 60 days of enrollment. So even having seen a nephrologist for a considerably long period of time prior to starting dialysis, the majority of patients are still starting with a catheter. If we go on to the next slide, this is looking at AV access placement prior to starting dialysis. And again, this is among patients who've seen a nephrologist at least for 4 months prior to starting dialysis. And again, most of them actually have seen a nephrologist for 6 months to a year prior to starting dialysis. And what we see in the United States, half of the patients, 55%, have had an AV access placed prior to starting dialysis, and nearly 50% have not had an AV access even placed prior to starting dialysis, even though they've have seen a nephrologist for at least 4 months or longer prior to starting dialysis. The UK has had a very focused program going on in the UK to improve fistula use in the UK. And here you can see in the UK that they now have 81% of their patients, if they've seen a nephrologist for at least 4 months, 81% of the patients have had a fistula placed prior to starting dialysis. And actually, fistula use in the UK has increased from 67% up to 80% just in the last several years as part of this focused initiative in the UK. And again, you can see in a number of other countries, in Japan, Germany, Italy, where over 70% of patients have had an AV access placed prior to starting dialysis, given having seen a nephrologist for at least 4 months. So I think we just have a couple more slides here. This slide is from a medical director survey. So the medical directors of each of the study sites, we asked them, what's the typical time from the time of creating the AV access to when you cannulate it? And the U.S. actually has one of the longest typical cannulation times of any of the countries that we see in DOPS. In Japan, in all of the other countries, it's the great majority of the facilities, the typical time is 2 months or less. In Japan, it's actually 1 month or less. And they also have lower blood flow rates in Japan, which makes that feasible. But in the United States, 72% of the facilities indicate the typical time is more like 3 to 4 months. And so then this then affects the ability then to be able to start dialysis, for instance, with a fistula if it takes longer than to cannulate it for the maturation process. Next slide. So there's just one slide we're going to show you then from a study that we presented at ASN this year, led by one of our country investigators from the UK, Dr. Hugh Rayner. And here we look at the rate of bacteremia that's reported in DOPS, and that's number of bacteremia events per 100 patient months in relationship to a country's percent catheter use. And you can see that there's really quite a strong relationship that generally speaking, in countries with higher catheter use, that there are higher bacteremia rates. Now, there's some variations off of the main line, as you can see, which certainly could exist. In some countries, you may be better at taking care of a catheter, or in some clinics, may be better at taking care of a catheter than in other settings. But overall, so even in Canada, having much higher catheter use rates, still the rates of bacteremia, for instance, are nearly twice as high as they are in the UK and the US, for instance. So I guess we'll just conclude then and say that large improvements have been observed in the United States from 1997 to 2013. Fistula use has risen from 24% to 97% to 68% in 2013. Catheter use has declined now to 15%. Graft use is twice as high among Black versus non-Black patients. And during the period of bundling, fistula use has continued to increase, and catheter use has continued to decline, which is really great to see. However, at dialysis initiation, fistula use remains very low at about 18%, and catheter use remains very high. Patients are typically starting, about 80% of patients are starting with a catheter. So even though with all of the great progress and improvements made in prevalent patients, there's still there has not been any improvement in terms of access use for incident patients at the start of dialysis. And I think with that, we'll, I guess, go to the answers to the polling questions.
Sure. Thanks to everyone who responded to the poll questions. Here's actually some data that we had asked of some of our nurse study coordinators in the United States in 2012 about whether patients who were using an AV fistula, whether they were cannulated with the buttonhole technique. And you can see back in 2013, about 31% of facilities said that none of their patients were using the buttonhole technique, and about 43% were using a small proportion of their patients. Pretty similar to the results that were observed here as well today. And we also asked questions on the poll about whether the QIP measures were affecting how their AV fistula use, and their emphasis on that graft use, as well as minimizing access-related infections. And in the majority of you, 58% reported that there was a greater emphasis on AV fistula use. Most of you, 65%, said there was little or no change in their emphasis for AV graft use, while again, a majority, 65%, said they were more emphasis on minimizing access-related infections.
Oh, that's really interesting. Yeah. Oh, great. Well, thank you very much for responding to the poll. It's really interesting to see those results.